Perfect. Well, as people continue to file in, I'm going to sort of start us off by welcoming everyone. Thank you for joining the week before or the Tuesday before Thanksgiving. And welcome you to everybody online who's watching this virtually. My name is Eric Wagner. I'm honored to be joined by both Chris Clifto and Matt DiPaolo, and even more honored that we have three amazing experts, Doctors Michael Hausman, Joe King, and Mark Morey, to join us to talk about total elbow arthroplasty, or arthroplasty in general, and some of the controversies and important points that will be highlighted throughout these articles. Chris, do you have anything before we lead us off?
No, please, if you have any questions, put it in the chat, and we'd be happy to get it to the panelists to answer. Otherwise, let's have some fun.
Perfect. Awesome. So Chris, why don't you lead us off?
Okay, sounds good. So I'm going to be doing intraoperative modifications of total elbow arthroplasties, and this is out of Mayo. So this is a study that looked to evaluate modifications of total elbow arthroplasties. The purpose of the study was to investigate the prevalence and consequences of implant modifications during TEA in a single institution. The authors hypothesized that the total elbow implant modifications would be more common in revisions than in primary replacements, and that they would not be associated with worse clinical outcomes, increased rates of radiographic surgical complications because of the implant modifications. Aside from the modifications were included from patients over a 25-year period, the authors also sent out a survey to other institutions regarding modifications to the implant. There were 106 implants that were modified. 60 of these were revision cases. The most common modification was shortening of the stem, bending of the stem, notching of the stem, and tapering of the stem. The overall complication rate was 51%. Over half were not related to the implant. Of the remaining implant modification complications, less than 50% were related to the modification, with only 2 of the 17 probably related to the modification, according to the authors. There were no implant failures due to the modifications. A total of 442 survey responses were then received, representing 29 countries, of which 144 surgeons performed modifications to implants during TEA exposures. Procedures. The study concluded that complications possibly related to implant modifications were at a minimum 15%, and they could be as high as 30% if patients lost to follow-up also had complications. And they say that implant modifications may be necessary in some cases, but if done well and thoughtful, they can be beneficial. So the first question is from Mark, since this is your institution. Mark, what crazy shit are you doing in Mayo? What the heck is going on? You're modifying implants? What is going on?
Yeah, it is a little bit cray-cray. No, not really. When you think about, let's go back in history a little bit and just talk about what are the indications. So it's 25-year history. And predominantly, we were doing total elbow arthroplasties for the rheumatoid population early in the history of elbow replacements. But now the most common indication for elbow arthroplasty is trauma or the sequela of trauma. And in the sequela of trauma, you don't have normal bones, so you have very abnormal anatomy. So you need to be able to solve those kinds of problems. And there isn't a custom solution for every patient. So in order to manage costs and get the implants where you need them to be, many times you need to bend or bevel or cut short an implant. If you can imagine, a shoulder replacement from above with a super long stem, modular SRS, say, for example, from the shoulder, for those who do shoulder replacements, and you've got no bone to work with, what are you going to do when the patient needs, an elbow replacement too? I mean, you're not going to do it. So in those cases, we've cut stems. And a lot of the history now is, what do you do with a patient who's failed multiple times and you need to do an allograft prosthetic composite and you're building up bone and those canals don't line up perfectly and you've got to sort of negotiate those canals. So there's a variety of reasons for modifying them, and those are probably my most common. And I think it's actually crazy not to modify an implant if the implant is going to go outside the bone. I don't know. That's just me. You can call me crazy.
No, that's fair. Hey, Dr. Hausman, what are your thoughts? Like, what situations do you find yourself, either modifying the implants or really modifying the technique, and maybe give some tips to how to improvise with elbow. Because there's a million options when you do shoulder replacement, and you could probably find anything you want to do within one of the implant companies, but that's not the truth with elbows. And as Mark just pointed out, I mean, you're often in the OR and you're like, man, this is not fitting like it needs to be fitting. This is not a work. What do you do in those situations?
Well, I think the number of situations where you don't have an inkling of this happening ahead of time is relatively small. I mean, such situations will arise, and in that case, you have no alternative. But as this data shows, it's somewhere between 15 and 30%, and even 15% for this operation, is a real concern. So I think you want to optimize your pre-op planning. If you need a custom implant, some of the manufacturers will create that for you, so that you don't have to basically cut up and polish the implant in the OA. That said, there will be situations you're generating heat and maybe even microfractures. You're certainly changing the metallurgy and the surface of this thing, which may or may not be pertinent. But you want to make those situations as infrequent as you possibly can.
Can I push you on that then? Teach us, what are you doing when you're planning, not necessarily a revision, but a complex primary elbow? Talk us through, how are you determining that ahead of time? Using software? Are you using the CT scan? Are you using your X-rays? Like, what? Talk us through your pre-op plan for a complex primary elbow.
Sure. I mean, it's relatively primitive. I'm using the CT scan to take measurements in zones where I think it's going to be close. And then obviously, if there's a shoulder prosthesis above, you want to make sure that you have adequate clearance there and the appropriate length.
Perfect.
Can I custom implant? Dr. Hausman, you mentioned that. Are you often doing custom implants for complex revisions?
No, I mean, bear in mind, I think I'm the sort of provocateur in this group, because total elbow is an operation that I'm not really happy with. I think, it's a little arch to say it, but the thing that prevents the failure rate from being higher is that the patients pass away before the elbow fails. And as I've often said, as people become older, they don't become lower demand, they become quadrupeds. And all older people use their arms for getting out of a chair and locomotion. So I'm trying to minimize this and do everything possible to reconstruct with autogenous tissue.
That's
I just
great.
wanted to say,
Mark, what were you say?
No, go ahead, Mark.
I mean, it's a fair point, but if you look at the history, there's two papers that I would counter that. So I do think that total elbow arthroplasty is a salvage operation. So, I mean, you have to go in with that clear mind. But, the history is, so in rheumatoid patients, 92% survival rate at 15 years with an older implant. And those are patients who needed to bear weight. John Barlow showed that patients don't listen to our restrictions anyway. I mean, they're chopping wood, they're doing what they can. So I think that data is real. The data is the data. So while certainly, I would like it to perform longer and stronger and be a higher demand implant, 92% at 15 years is equivalent to a hip replacement. So I think we got to be a little bit careful. If it's indicated, I would fire away with a total elbow arthroplasty. I mean, I saw a 58-year-old in clinic today, and that elbow is trashed, and I am unwilling to have that patient go through long-term suffering without having a solution. And I do interposition arthroplasty, so it's not like I'm saying, do nothing.
Right.
But when you
So,
got
all right, let me
bone,
push you on that then, Mark.
Yeah.
Then your indications for talk to us about a late 50s who has elbow arthritis. When are you scoping debriding them? When are you doing interposition arthroplasty? When are you doing a total elbow?
Yeah, so that's a great question, and it is a salvage. So today I had a patient. He's 53. He was a high level pitcher. He's got rheumatoid arthritis. His right elbow and his left elbow are both trashed, and I offered him a synovectomy and debridement. So when am I gonna? What's the next step up the reconstructive ladder? I'm not going to offer him a total elbow arthroplasty. The next step up the reconstructive ladder, as long as he's stable and has good enough bone stock, would be an interposition arthroplasty in my hands. And then if he fails those three things, again, it is compassionate use of the elbow replacement to get people out of pain and be able to function. So then I'm offering a total elbow arthroplasty. So every patient's different, and it matters what their goals are, how much pain they're having, and what their articulation looks like, whether it'll handle a something else before elbow replacement. Because I'm oftentimes offering that.
Mark, can you speak to the interpositional arthroplasty? It's not a procedure I've done often. In fact, I think I've only done one, and it actually worked very well. But are there any modifications to the techniques that you're doing now? Take us through that a little bit. Any tips or tricks for success for that procedure?
Sure. I mean, if you look at any of the papers that were ever published, including our own out of our institution, interposition arthroplasty fails by instability. So in our series happens at about 8 years. And their male elbow performance scores are not great. But it's the goal of the patient. What do they want? If they want a higher demand elbow and they're, want to throw a ball, then elbow replacement is not something I'm rushing right into. I use an Achilles tendon graft now. Historically we would use fascia lata and then migrated to Achilles tendon because it's a little bit thicker membrane. And we historically had been using a lot of external fixators, and that had two benefits. One was, you got it sort of a free manipulation or examination under anesthesia when you took it off, so you could help with motion because a lot of these patients are stiff. But I think in today's era, people do not want the external fixator, and so that's been a big change. So it's very rare, and I cannot think of a patient in the last decade that I have actually used a fixator. But because we know what the failure mechanisms are, we're augmenting every single ligament repair when we do an interposition. So we take a sleeve of the Achilles tendon and we wrap it up and reconstruct both ligaments on both sides in almost every patient. Now, if I'm hinging it on the medial side, then I'll just do the lateral side. But many of these patients, it's an augmentation in addition. So it's similar to, offloading, suture that we're doing for the MCLs, for example.
Oh, that's perfect. Yeah, Michael or Hausman, I know you've had a very rich experience with interposition. Do you want to talk about maybe some technical tips that are slightly different than what Mark just said?
So you're correct. I do many, many more interpositions than total elbows. And there are two things, and I think this paper is coming out soon, two changes that have really extended the indications and improved the results for us. One is the use of meniscal allografts as the interposition material rather than fascia lata or Achilles tendon, it's just not designed to be weight load bearing, and it's just not robust and strong enough. But menisci are exactly designed to bear the body weight and load, and they work as well in an elbow as they do in a knee. They also, when you bend the meniscus shape, it actually forms a trochlear shape, so it imparts considerable considerable stability to the elbow. The second thing that has helped with the instability problem, and I think Mark's point is key, that you need adequate bone stock and you need stability, is the use of not an external fixator, but an internal fixator. And so our current construct is actually two of these devices, medial lateral, so that they form essentially a triangle with the apex being the ulna. And this is very, very stable. And so we can extend the patients that we can offer interposition to. So for a post-traumatic case, even a bad rheumatoid, younger, active patient, that's my go-to.
And so the internal, you're talking about IGS, right?
Yep.
And are you leaving those in? When do you take those out?
I leave them in.
Okay. Very nice. Very nice. All right. Well, why don't we go on to the next article unless anybody has any other comments. So the next article is on humerus hemiarthroplasty versus total elbow arthroplasty. It's the Australian Registry article. So this was a cool article. It looked at 2005 to 2021, so a fairly large period of time, looking at the indication of a distal humerus fracture, either doing a total elbow, which 631 of them had, versus a hemiarthroplasty, which 293 had. Hemi was overall younger when you looked at the indication, about 10 years younger than total elbows. And then when you looked at their overall outcomes, the 9-year revision, which was their ultimate endpoint, it was 9.7% for Hemi and 11.9% for total elbows. And when you adjusted for age and gender, there was a higher risk of revision for total elbows than with Hemis. Hazard ratio was over 2 at that point. And in general, no difference for the young or the old, less than 55, over 75. Most common cause of revision for the total elbows was loosening at 3.6%, and was instability for the Hemis at 1.7%. And then the most common revision procedure performed, the total elbows, actually, interesting enough, was their humerus. And for the Hemis, the most common revision procedure was actually adding an ulnar component. So really cool study, great database study. This Australian registry has been really powerful for both shoulder and elbow. It basically kind of showed that Hemis potentially have lower rates at revisions than total elbows, and that in general the loosening does increase with time, especially on the humeral side if you look at that sort of Kaplan-Meier survival curve. So kind of interesting. The Europeans have also been pushing hemiarthroplasty, so it's kind of a cool study, thought-provoking study. So Joseph, when you have a distal humerus fracture, can you talk to us about sort of when you are fixing or when you're considering some aspects of arthroplasty? So what's your indications for the different mechanisms of treating it?
Yeah, so I'm really trying to fix as many of these as I can, right? Anyone that has decent enough bone that I think can hold some screws, even headless screws with an electron osteotomy for small fragments in a younger person. Younger might not necessarily age-wise, but physiologic age. Some of our 70-year-olds are younger than our 50-year-olds here in North Florida. But that's really important. And then the amount of comminution, obviously. If there's a bunch of small pieces that have minimal bone, like a lot of cartilage, no bone on them, that aren't going to work, those are the ones I'm leaning towards, either bag of bones or arthroplasty. I'm definitely willing to do hemiarthroplasty. I know the problem in the US is it's the sizes are limited what we can do, and it's off label, but I tell the patient that, and I think sometimes it's the best thing for them in a younger patient that's a high demand, or a high demand patient, again, not even necessarily young. I think hemiarthroplasty is reasonable, and an older, lower demand patient who's not going to put that much stress and is able to do some weight restrictions. Whether they listen to me or not, I'm not sure, but if I think they're able, then I'll consider total elbow for those. But I'm really trying to fix. I push fixation as much as I can.
Fantastic. No, that's awesome. All right, Mark, you're one of the most creative surgeons I've seen. I've seen you turn hip stems. I've seen you personally turn hip stems into shoulder replacements and vice versa. You've done all kinds of crazy stuff. It really, when you started back right before I left Mayo. So tell me, are you doing hemiarthroplasties for just humerus fractures? And if you're not, what's holding you back from doing it?
I am not, because we ran out of the Sorby implant. So, I think if we had a reliable option that was more anatomic, I would be doing them, provided the ligaments are intact. So I think, in the situation where you've got, a low transcondylar humerus fracture that's really smashed, I think it's a great indication, because you can render that elbow stable. So I think it's a little bit like interposition. If you can make the elbow stable, or it is inherently stable, sometimes you're in surgery and you're looking at the smashed distal humerus on one side and this perfect ulna and radius on the other side, and it's just you feel almost immoral to replace that. But I'm like Joe. I actually I try to fix as many of these as I can. Our early experience may have suggested that they may have a higher complication rate if the ORAF failed, but our later experience doesn't bear that out. So I think you can attempt an ORAF, and I will oftentimes do that first. And I'm very excited about some of the technologies like Restore 3D, for example. Now that's the turnaround time isn't fast enough for an acute fracture, but I think it will get there. And so this idea of patient-specific matching and instrumentation for a hemiarthroplasty, for compassionate use, or for point-of-care manufacturing, I think it's going to be a real thing in the next few years. I really think that technology is exciting for not only this, but for what we talked about earlier, which is not having to modify implants.
So
printing
you think
set
that technology
works.
is going to beat us getting one of the more anatomic total elbows like they're using in England or France or Australia?
Yeah, I
I mean, the
absolutely think
hemiarthroplasty, sorry.
I absolutely do, because even now we're running into shortages because the companies are unwilling to invest in that and elbow replacements. So I think
Sure.
there are a lot of things that we can solve, or that we have pushed for, that haven't necessarily happened because companies are like, hey, this is a money loser, or it's the poor orphan stepchild in many cases. It doesn't have the volume that say shoulder has, or certainly not the hip and the knee. But I do think that that's a technology that then puts inventories in the hands of the surgeons who are performing the operations. So if you can print something, it keeps costs down for the company. It keeps costs down for the patients and the surgeons. I think that's an exciting technology that we will be seeing a lot more of, and probably doing a lot more of replacements if we can do things like hybrid fixation and cemented and uncemented, where, if our big problem is loosening, well, then let's solve that loosening problem.
Yeah. Mark, I'm sorry.
Go ahead.
So when you're about to take on
Mhm.
one of these possibly unreconstructible, very low distal humerus fractures that may need an elbow replacement or a hemi, what approach are you using?
So
Anatomy, triceps on, triceps off, etc.
yeah, so I will typically work on the medial and lateral side. So if I've got a really low transcondylar, I will go posterior and I'll work on both sides of the triceps. If I think that it's nearly unreconstructible, or I'm going to attempt it, I will work on both sides, and I'll work to the medial side and work to the lateral side. It's a long way with a posterior incision, but I think you have to have a peek into the front of the elbow. You cannot see it otherwise. Even with an osteotomy, many times you can't see the front as well as you'd like. So I think you have to be comfortable going from the medial side and going from the lateral side. And as long as you're safe with the soft tissues and you're not enucleating the soft tissue envelope, I think you can make a posterior incision and then make an anterior lateral or an anterior medial incision and get to what you need to get to see and do the operation if you think you can fix it. So I feel comfortable doing that. So I'm not hesitating to make another incision on the skin.
So, Dr. Hausman, how about you? Are you ever doing total elbows for disc ligament fractures? If so, when? Or if not, what's your sort of tips and tricks with some of these really, really smashed, complicated disc ligament fractures, especially in older patients?
So there are certainly cases very low, medial epicondyles off, trochlea has coronal split, where it is unreconstructable. But I think that is very rare. The approach that I tend to use is an olecranon osteotomy, and then take down the lateral side so that you can spin around and get to the front of the humerus. And I plan these as a two-stage procedure. And I tell the patient, this is going to require, number one, putting everything back together if we can. But then we're not going to move your elbow because it's not stable enough. And we're going to let it heal for 3 months or so, and then rehab. And then if you're stiff, you get an elbow release, which is a pretty reliable procedure. So that's been my approach. If I do have to do a hemi, I've used what's available, but as has been mentioned, it's anatomically incorrect, and it doesn't fit the way it should.
And are you scoping the releases, or are you doing the releases open, given it's cutting a fracture?
Most of them are scope. I leave the ulnar nerve in situ, so I know where that is, but I wouldn't hesitate. I mean, whatever you're comfortable with. I don't think there's a difference in outcome.
Perfect.
Another trick to get into the front, for capitellar fractures, if you have a lateral epicondylar fracture, you can kind of just peel the whole thing off and spin it up. That's nice. Do the capitellum first, then put that back on. I do
that's a great idea. I love that. It's a lateral epicondylar osteotomy is a lot of times
it's easy. It was done for you, basically.
Yep.
And I actually like the lateral paraolecranon approach for the low ones, where don't have to put a plate real high. That's really nice to see more posteriorly, and you can still do an osteotomy if you had to. So I've been doing that now for all these. Unless I really want, unless I really need a long lateral plate, then I won't do it. But you can still get around the front if you had to that way. And you can still do an osteotomy if you had to.
I really like the idea of windows. You can, lateral paraolecranon approach is a window to the elbow, and you can use other windows. You can make a skin incision somewhere, but then work similar to an acetabular fracture or a pelvic fracture, where you're working through different windows in order to get what you need to gain the reduction or to see. That's been a very successful strategy for us.
Mark, can you talk about that? So what's your tips on how to do these windows?
Well, like for example, let's say you're going to do a lateral approach to the elbow, and you the ligament is intact. You don't want to violate the ligament, right? Everybody talks about, well, let's do a Coker approach or let's do a Kaplan approach. Let's just take that one simple approach. You can work on both sides of the ligament. So you make a Coker incision, right? Now you are down and you can dissect in front of the ligament. You can make a window, split the EDC, and get down to the front part of the radius, for example, if you need to fix the radius. And then you can work in back of that ligament, for example, if you need to do an anconeus interposition arthroplasty. So you can slide the anconeus underneath the ligament without ever taking the ligament down, and work in the windows in front of the ligament and windows in the back of the ligament. And in a similar way, you could make a lateral approach, and that's one window for whatever. With ectopic ossification removal is like a common reason I would do this. HO everywhere. I'd make a lateral approach and I'd go in front, more in a column approach, and then flip around and go to the medial side too. Not raise huge skin flaps. You avoid complications that way, but working through both of those windows to get the job done.
What about just some very practical questions about positioning, patient positioning? I know some people like supine, some people like lateral. Anybody have different thoughts on that based on fracture pattern and, you know, probability of converting to an arthroplasty? Anybody have any thoughts about that?
I prefer to go lateral or lateral for most of these over a paint roller. Unless it's a true just capitellar shear where I'm going to do a capillin or something to get to the front. I'm mostly going posterior for these in a lateral position.
I think a lot of it depends on the comfortability of your room staff and the OR techs and how you're set up and what you normally do. You know, I'm comfortable looking at it with the arm over a bolster, and then bringing the arm down to the side for the X-ray. So typically I'll do it supine.
I go supine with a shoulder positioner holding the arm over the patient's chest, and you get a little helpful distraction that way too.
Very cool.
Hey,
I
can
I guess I'm just not good at operating upside down. I'm just not that good.
it's all what you're used to, right? I mean, if you train lateral, I wouldn't suggest to you, you know, you must do it supine. You know, I think that's ridiculous. It's like somebody who's only done a 1 incision distal biceps tendon repair and then telling them you have to do a 2 incision, although I think you should. You know, if you've never seen it and haven't trained that way, then, you know, fire away with the 1 incision. Hey, can I share my screen just to, somebody brought up planning. And that was brought up a couple of different times. Let me just show, I think it's helpful to look at a couple of different examples. Let's see. I think this will work. Okay. So, can you see that?
Yeah.
Okay. So this is a patient that had this, all of this bone is dead. She ended up with a humeral APC, allograft prosthetic composite with a femur, so a distal femur. So the pre-op planning and steps that I go through, I'll highlight sort of and this is that's the post-op. But here's another patient. So this would be a patient that, you know, I'm worried that stem is going to come out right out the back. So like Michael, I will get the 3D CT, and then I will scale that according to the implants. And this is totally the low budget templating software, because I can bend it where I want and I can do a phantom, you know, on PowerPoint, but you can scale it so that it is a match to the patient. So this is a medium implant. So I knew I could plan for a medium, but I knew I was worried that I was going to go out the back in this patient. Here's another one. This was going to be a large implant, you know, from the side, but you can get a lot of information by resizing just with PowerPoint, as long as you have a reference marker and you can size the implant. And you might say, well, how do you do that? How do you size the implant? It's pretty easy. If you've got a little marker, a measurement tool like this, then all you have to do is draw a line and size to that line, and then you can get the exact sizes. So this has been a big game changer in terms of my planning and knowing whether or not, you know, with this stem, was I going to go out the back? Like, that's a bad day in the OR. So the more you can head that kind of stuff off in the past, the better. So this is one that I bent, I shortened, and I beveled it because I was very worried about the PUTA angle. This person had a very hyperacute. You see that sometimes in patients with osteogenesis imperfecta. But I've gone to this, you know, it's very, very helpful in preoperative planning in order to avoid, you know, say taking down the triceps or removing the triceps if you can't do that. I mean, obviously that's a bad day in the OR too. So you want to keep the triceps attachment, but you still need to be able to negotiate the canals. So it's just something that I've done that I think everybody can. It's super easy to do. You just need the CT scan, and even with programs like Resolution MD, you can see with fair regularity that I am modifying implants. But you can see with like software like Resolution MD, you can get the 3D reconstructions even if you just have a 2D image, and then you can plan. You can see things like, where is the triceps? Where is that going to be in relationship to my implant? How much of the tip of the olecranon am I going to be removing? Am I going to have impingement in the front. So those are the kinds of things that can really get you into trouble with early loosening. So you want to know that before you put the elbow replacement in. So just something that anybody can do. And if you want more information, I can certainly share it with you.
That's fascinating. That's free software?
It's just on PowerPoint. I mean, all you have to do is get the implants and put a reference measurement on your implant trials.
Yeah.
And then you just draw a line on your CT scan, because you can easily measure that. And then you just size the implant according to that line. So for example, a medium is 60 millimeters from the entrance point to the tip of the stem. So I just size according to that. And then that's your templating, because a good templating software doesn't exist, or at least I'm not aware of one.
Sure. That's fascinating. That's awesome.
I would say your results are probably better when you do these modifications, right? You're bending the ulna. There's probably more you're offloading some of those forces, and especially in the humerus too. Instead of a straight implant, some of the rotational forces, you're probably improving your
Yeah, I think it does matter like what type of implant you use. As Michael said, you do change, especially with titanium. If you bend titanium, you really do change the metallurgy. So there's been a couple of patients that my dad had done allograft prosthetic composites where he had to bend the implant in order to get it into the native bone, and those patients fractured. So that's true of the Coonrad Mori, but with the cobalt chrome implant like a Latitude, you can bend that, and if you bend it once, I don't think that significantly alters the stresses. At least it hasn't seemed to do that with that particular implant over time. So yes, and I do think you can get a better result. I would much rather do that than go out the back of the ulna.
Yeah, absolutely. Very cool. Chris, why don't we go on to the next one?
Yeah, absolutely. Okay, so the next article is one looking at the re-revision rates in patients who underwent revision total elbow arthroplasty, specifically for humeral loosening. They hypothesized that a proportional increase in the stem and flange lengths would stabilize the bone implant interfaces significantly more than a disproportionate increase in stem flange length alone. The authors also hypothesized the indication of the index arthroplasty would contribute to the need for re-revision. The secondary objectives were to analyze functional outcomes, complications, presence of radiographic loosenings after the total elbows. So they looked at 181 revision total elbows that were reviewed between 2000 and 2021. There were 40 revision total elbows that met criteria of humeral loosening with a minimum of 2-year follow-up. Patients were based on stem and flange length. The stem to flange length ratio was calculated for each revision. The mean length of follow-up was 71 months. RA was a significant predictor of re-revision rates, and overall there was a re-revision rate of 25% and an average of 4.2 years. There was a significant decrease in stem and flange length by 70 millimeters and 30 millimeters. Of the re-revisions, 4 had excisional procedures. The average flange length was the average flange in 7 cases was 7 times shorter than the average stem length, and the ratio was significantly different from cases that were not re-revised. So complications included ulnar neuropathy, radial neuropathy, infection, ulnar loosening, and fracture. None of the elbows were radiographically loose at follow-up. So the authors concluded that a primary diagnosis of RA, humeral stem with a short flange relative to the stem length, and specifically where the flange is less than 1/4 the length of the stem, significantly contribute to re-revisions of total elbow arthroplasty. So Dr. Hausman, what are your thoughts on the flange? Do you think it matters?
I think it does. I mean, this paper would indicate that it does. There are other studies. So I think having the flange and particularly bone grafting between the anterior humerus and the flange is important.
Yeah, no, that makes sense.
I'm not sure if it's the exact length of the flange to stem ratio, but if you've got longer flange makes more sense. But as long as it's got to be on bone, right, the whole way. So if you got a long flange, only a little bit of it's on bone, it's not going to make that big of a difference. So I think you got to make sure there's some bone there to make it count.
What do y'all usually use for bone?
So after reading Maury's paper, I think I'm gonna start bending my flange. I like that idea.
No, so I would caution against that because Michael is absolutely right. It is the bone graft. So there's the physics principle is called the polar moment of inertia. So the further away you get, the rotational forces are resisted. If you bend the flange right up to the native humerus, you basically get the radius, and if you flange is engaged, you get radius to the third power. But the further that is away from the center of rotation, you really powerfully logarithmically decrease the torsional stresses. And I think, early on we looked at the flange was developed because it resisted posterior directed forces when you bend your elbow, because that's where the vector is. And that's why the flange was developed in the first place. I mean, my dad was throwing up x-rays time after time after time, and all the stems were pointing out the front because the articulation was going out the back like this. So putting the flange on there resisted that, and that bone graft resisted it a lot. So ones that go right up against the cortex oftentimes end up in the intermedullary space. But if you have a bone graft behind it, and we found that with the APCs. So if you put a long bone graft, a long strut extension behind that flange, you can get really good incorporation and really good not only resistance to the bending loads or that posterior directed force, but also the torsional stress. And our failures for humeral APCs were all torsion. We use our arms out here like this. So you have a tremendous amount of torque on those. And that's why all those megaprostheses fail. None of them have a flange. So I do think that the flange ratio is important. Gabor Puska studied that when he was at our institution. And that ratio, I think, does matter. We don't know what that is, but I am using, even in primaries, a long flange implant at this point because
the failures you mentioned in the APCs, were you plating those as well? Or was the or those APCs just the long stem bypassing the junction?
That's a really good question, Eric. So of the ones that failed most commonly, they were the intussusception type, and they were not plated. So they were wired shut, and a lot of times they had an episiotomy on both sides of the humerus and then wired closed. But that wasn't enough force to actually to prevent that, even with the flange. And we know that the flange needs to be engaged. I mean, that's one of the reasons you need an APC. If you don't have flange engagement, that's a high failure mechanism. And our subsequent paper to that, just looking at humeral APCs, shows that if you add a plate to the construct, obviously that also helps you with your rotational stresses. So I think it's important. It's important from just a basic science and physics perspective. But this is really clinical data that's helped to back up the basic science, which I think that's what we're all about, right? Scientific basis of our clinical practice.
Moment of inertia. I mean, so many big words in this explanation here.
Right.
Sorry.
Okay. I know.
So what bone graft?
Torque people.
Yeah. What bone graft do you guys use? I used the split tibia the last time. That worked pretty well, but it was a pain in the butt to burr down.
Yeah, in a revision setting, I'll use a strut femur, or if I'm doing an APC, I always step cut the allograft so that I can get a strut extension. And many times I'm using a femur for distal humerus and a proximal humerus for the ulna. And usually I use a proximal humerus with cuff because then I can reconstruct the triceps. So if you've got no olecranon, a lot of times the triceps is off. But if you've got a cuff attachment, then you can reconstruct the triceps at the same time. So Joaquin published a paper about the allograft ulna with triceps, reconstructing the triceps. We're getting our data together for the proximal humerus with cuff and reconstructing the triceps. It just gives you a much more robust graft, I think.
The proximal humerus as opposed to the ulna with the triceps on.
Yep.
Fascinating.
So obviously the triceps got to fit. It's got to reach. So It's better to have an ulna if the triceps is really contracted high. But most of the time it scars to the back and it's in the vicinity, so you can use the cuff and you can get a fair amount of length with that with a proximal humerus with cuff. So that's been a game changer in my practice recently, especially in a man who an ulna just isn't going to fit. It just doesn't fit well to put another ulna over the top of it. You really need to have a more robust graft. So that's something that has changed in my practice over the last 8 years.
Dr. Hausman, any tips from your standpoint when you're optimizing your humerus and you're hoping to prevent complications associated with maybe humeral loosening or whatnot? In your mind, when you see humeral loosening, like one, how do you optimize preventing that? And two, when you see it, what do you think is the main reason why that happened?
I mean, it's probably the torsional forces, or if the flange is inadequate or isn't grafted, that bending force that Mark just spoke about, where the proximal portion of the stem goes anterior. Yeah, you know, I guess my other sort of preference, if I have bad cement disease from primary total that is going to need to be revised, what I'll do is try to put the prosthesis inside an allograft and then intercept the allograft into the humerus with bone graft, so that I'm moving the cement bone interface to the junction between the prosthesis and the allograft, rather than the prosthesis and the native bone.
Makes sense. Makes sense. Mark or Joseph, any other last comments on tips that you can give the fellows or residents optimizing the humerus?
Yeah, I think, the first thing, is just a good cement job. So, pressurizing the cement, making sure the canals are clean and dry. I mean, just basic principles. You don't have a whole lot of cancellous bone. So one of the things, that I learned early on was you don't want to overwork the bone and remove the very thing that you're going to cement into. I mean, we do tons of revisions where we're combining techniques with, for example, impaction grafting, so that you can actually have something to cement into. And so I would say, just, if you're faced with the situation where you've got to, do a good total elbow, the way you do your cementing does matter, and just try not to remove too much of the cancellous bone, because you don't have a whole lot there. And then pretty soon you're going to be looking at a porcelain bone, and that's a really tough problem, because the cement just doesn't grab to that. I mean, we went down that history. If you think about like how we used to teach people many moons ago how to cement a glenoid in that had an abysmal failure, was we used to say, well, you got to remove the cancellous bone. Well, everybody knows that is absolutely ridiculous. That's probably why some of the older data favors, pegs over keels. It was just a cement technique. It was like they were removing the whole vault, which is ridiculous. So I think you just have to be really careful about, not overworking the bone, and think of it as a grout, not a glue.
Makes sense.
Adding
That makes
topical
sense.
stuff too, like TXA and thrombin is helpful too. Get it dry.
Yeah, and there's no good cement restrictor. So one of the total game changers in my practice is take Fibrillar and use Fibrillar as your cement restrictor, because you can pack that thing in there really tight. It gets a great cement pressurization. And then if you hate it, you can just take the little chugga and get rid of it. So it's so flexible, and it saves so much time. I got that little gem from Jeff Hughes in Australia. And I was like, where has this been all my life? So I've just started doing that in the last year. And I'm like, oh my gosh, this is awesome. Fibrillar. Just use Fibrillar. It's the best cement restrictor out there.
Interesting.
We have a question from the audience here. Maybe we go down the panelists. So the question is, if you plan to try and fix a distal humerus fracture and perform an olecranon osteotomy, do you feel bailing to a TEA is no longer an option? One recent paper in JSES showed that authors were performing olecranon osteotomies for primary TEAs, but my training has typically taught me that this is a contradiction. What are the panelists' thoughts? Maybe we could start with you, Joe, and then go to Mark and then Dr. Hausman.
I mean, I think if it's healed, I don't think it's a contraindication. I've done it before. So I think it's reasonable to do if that bone is healed. I worry about it some, and any patient I'm really worried I'd get a CT scan to prove it. But I'm usually, you're doing that anyway for planning. So, yeah, I don't think it's contraindication anymore. I know that was the traditional teaching, but I don't know. I'm unaware of any papers that have showed that though.
Mark, what do you think?
Yeah, so I would say that it is not a contraindication at all. And what about the times where you've got an olecranon osteotomy and you have to put a total elbow replacement in? So the way to manage that is to put wires right into the cement mantle. So typical tension band construct, and you could solve that problem by getting the olecranon back, and those heal reliably. I've got a couple of pictures. I was just trying to see if I could find them, but that is a common question. Here you are. You've already done your olecranon osteotomy and you're like, uh-oh, now I can't fix this thing. What am I going to do? Well, you put in your total elbow. It's really easy to prepare the ulnar canal when the triceps is out of the way. And then when you put it back, you just have to make sure that you burr out the what you need for the implant, and then put wires right down the olecranon, right into the cement mantle, and you can wire that back on. And that's very reliable. That's a little gem that I learned from Sean.
That's awesome.
Dr. Hausman?
Yeah, 100% agree. I think an olecranon osteotomy is actually not a terrible approach for a total. So I wouldn't hesitate to make it if I'm trying to put a distal humerus back together, and if it just doesn't happen and it needs a prosthesis, as Mark and others have just said, it's not a problem.
Very cool. Well, why don't we finish up very quickly, unless anybody else has anything else to add with the radial head arthroplasty. So the radial head arthroplasty revision analysis, this is looking at 14 medical centers in the Kaiser network, 75 surgeons looking at radial head arthroplasties for fractures. Found 405 radial head arthroplasties done. Mean age was about 51 years. Pretty good follow-up though overall. And one of the striking findings was the radial head diameter. So 26 millimeter diameters had a 7.7 odds of revision compared to 18 millimeter diameter heads. And if we were going to revise it, 95% of them revised within the first 36 months. Overall, their follow-up average was about 69 months. And in general, the TL triads did have higher reoperation rates than the radial head fractures, as others have kind of shown. One of the other interesting parts was that the Acumed anatomic was no difference than the 20 Evolve in almost every measure they looked at. So great study, large database. Interesting about the comments about the radial head diameter, something that I think we are a lot of us are attuned to, and sort of adding some nice data to this. And then also a comment on the ingrowth versus smooth stems. So just real quick to poke Mark a little bit. Mark, when are you from this? There's two points. One, when are you using ingrowth versus smooth, or are you ever using smooth? And then two, how do you see that conversation evolve over the next 10 years with regards to stem type?
Yeah, that's a great question, Eric. I think, my do I ever use smooth? The answer is yes. So in an older patient that needs a radial head replacement, it's quick, it's easy, and it is reliable for a spacer. So if your concept is, I'm just going to need a spacer until this heals, I think Graham King has shown wonderful clinical data with the Evolve prosthesis. Our data matches that. So both of our implants have a very low rate of revision. It's 3%. Over 15 years. So I think, it is do what you're comfortable doing. In a younger patient, I choose to use an anatomic radial head because I believe that the loads across the elbow are borne more when you're young. And 60% of the load is borne by the radial head when you're pushing, for example, and it matters more. So if I didn't feel comfortable getting it perfect, then I wouldn't do that. But I feel comfortable getting it perfect. And I think, if you just pay attention to what your cues are intraoperatively, then I think you can get it perfect too. And then, you pick which implant you philosophically want to use.
So what are those cues? How do you get perfect?
So I use fluoro. I use fluoro a lot. You have to reduce the ulnar humeral joint. So when you resect the radial head, for example, you want to put back in what you took out. So if you have an intact radial head, that's what you are using as a cue. Second is the proximal radial ulnar joint. You don't want to, you want to make sure that you can see that. And then third is take the elbow, bend it 90 degrees, push the olecranon up against the trochlea, and then you can't over lengthen a radial head because the over lengthening happens because the ligament is off. And then you can overstuff that quite easily. But if the ulna is reduced to the humerus, you can't overstuff that, and you just want to put back in what you took out. Those are the keys for me to get that right. So I do that maneuver. I take a shot under fluoro because the trials are radiolucent, so you can really match the curvature of the radial of the coronoid along with the radial head, and those should be basically coincident. And you can get that right reliably every single time.
Perfect. Joseph, anything else to add to that? So your radial head size I mentioned was something that obviously drove revisions, at least in this series. How are you sizing the radial head? How are you getting that perfect reconstruction matching the native radial head that you took out?
Yeah, I whatever I take out from the I put it back together on the back table, and I usually try to go down a size, right? So, and this study kind of shows that I don't want to overstuff it, so I'm typically going down and leaving a little looser. I'd rather be looser than a little too tight. So,
but Joe, so there's over widening, so you get your size with the width or with the length. So, right. I mean,
yeah, I'm talking about the width of it, right? Yeah. The length is harder. I mean, I think fluoro is the best way to do it. And then looking at it, like you said, I do like your trick of reducing the ulna. I think that's a great idea to help make sure you're not too long. But yeah, for the width, it's I go down the width size, but the length is I try to match what's there.
Perfect. And Dr. Hausman, do you use smooth? Do you use ingrowth stems? And regardless which one you use, maybe talk about some of your pearls and not making a technical error that's going to cause an early revision. As this article talked about, most are going to be revised very early if they're going to be revised.
Sure. So I use an implant with a sintered stem. So it's a tight press fit. It's not supposed to move. And then an adjustable head neck angle to try to reproduce that proximal final bend. I undersize intentionally by 2 or even 4 millimeters. I think the most common cause of overstuffing is probably an attempt to compensate for instability. You put everything together, terrible triad, and it's still dislocating. And so you take out the radial head and you upsize it until the elbow is stable. And I don't think you should ever use your radial head to stabilize the elbow. That has to be done with a ligament reconstruction. And if that doesn't do the trick, then I go, my threshold for an internal fixator is pretty low.
That makes sense. Perfect. And then, Mark, one of the challenges we have with with travel triads, and obviously that adds a whole other level of complexity. Can you talk to, as we finish this off, a quick, 3 tips that you can give people when they're doing a travel triad that has a coronoid, has an LUCL, maybe even MCL? Like, what are the 3 things you tell the fellows? Either do this or don't do this. To sort of optimize. So you talked about the radial head optimization. Talk about maybe a couple other tips you have before we sign off.
Yeah, so I would say you can put in and prepare for your stem and your radial head replacement, and then fix the coronoid, because the last thing that you want to do is be mucking around with the radial head after you fix the coronoid. So I would say that's kind of an order of operations that seems like obvious when you say it out loud, but when you're in the operating room and you're like, okay, I just got done fixing the coronoid and now I've got to go do my radial head. And I've got to, muck around with trialing and pushing something in and relocating on this thing that I just got done fixing. That's incredibly frustrating. So that is point one. I think that you should all be very, very familiar with an extended medial approach to the elbow, which is a very big game changer and will change your threshold for going medially and being comfortable going medially without having a high rate of ulnar neuritis or neuropathy. So I have a low threshold for reconstructing the ligament on the medial side. If after I've fixed those, the coronoid and the radial head and the elbow is still unstable, I am definitely going to make an incision on the medial side of the elbow. And so extended medial approach. The paper is by Bernard Yost. He's the senior author. I get familiar with that approach. It'll be a game changer for fixing the coronoid, but also for reconstructing the ligament.
Perfect. All right. We are out of time. Thank you all very much for very wonderful discussion and very, very stimulating. For those that are interested, this is recorded and will be posted. Steve included an initial email, but in subsequent emails, he'll let you know the location if those that are interested and want to listen to this that weren't able to make it. And then Chris is going to, I'm sure, post about this. So there'll be plenty of social media coming your way about it too. Chris, anything you want to leave with?
No, this is a great discussion, and thank you for clarifying a really challenging topic. I know everyone's going to get a lot out of this webinar.
Yeah, I think probably more questions than answers, but it's always fun to talk about it.
Yep.
Absolutely. Thanks all.
Good
Thank
night,
you.
everybody.
Have a good night, everyone.
Thank you.
You win.
Bye-bye.
Happy Thanksgiving.
Yeah, happy Thanksgiving, everyone.